be talking about refractive surgeries. We will be mainly concentrating on PRK, Lassic, that is microkeratome Lassic and femtolassic, and then lastly smile. So we know that the refractive surgeries are classified into lens-based procedures and cornea-based procedures. So today we will be focusing mainly on the cornea-based procedures. In that we have mainly the tissue subtraction and the tissue addition techniques. Now the tissue subtraction techniques, mainly we have the surface treatment, which includes the PRK and the epilassic. So the main mechanism is we use the excimer laser, the argon fluoride system. It has a wavelength of 193 nanometer and it ablates by the principle of ablative photo decomposition. So what are the indications of PRK? Now usually we consider PRK in patients with low to moderate myopia less than 6 diopters, and some people also do consider more than 6, but always the chances of haze are a little more, so we need to preferably limit to 6 diopters. Then in case of hyperopia, preferably about 3 diopters, less than that. Then in cases of astigmatism, we limit up to 4 diopters. And then in cases of deep orbit, so when there is a sunken eye and when there is a narrow palpebral aperture or a deep set eye, so in those cases PRK would be preferable, because in cases of Lassic and smile, the suction might be a little difficult, so surface ablation would be much easier. And then in cases of borderline thin corneas where the residual bed thickness is less than 300, so usually they say the RBT should be kept about like say 250, but to be on a very safer side, if we keep about RBT of 300 micron, and in cases of where the corneal thickness is less, in such cases instead of going for Lassic, PRK would be preferable and safer. And in cases of flat corneas and steep corneas, so we know that in Lassic we have chances of free cap in a flat cornea and buttonhole in steep cornea. So in such cases again prefer PRK. And in cases of form fruste keratoconus, a little bit detail of it I will be telling later. And those who engage in contact sports or occupations like in military, where they have a risk of ocular injury, so in such cases flap based procedures would be a little risky because it can cause flap dislocation if there is trauma, so surface ablation would be better. And also lastly, in cases of retreatment following corneal procedures, so if we have to go for an enhancement where the patient has already undergone like Lassic or smile, then the retreatment option PRK would be better. So this is the basic refractive workup which we do for all cases. So first of all, look at the age of the patient. It should be more than 18 years with a stable refraction of at least not changing more than 0.5 diopters in 1 year. Second, always ask for the contact lens history, because first of all, contact lens, long-term contact lens users will have dryness, and that has to be ruled out. And also if they are using contact lenses, we need to tell them to be off contact lens. In cases of soft lenses, usually minimum of 1 week, and in cases of RGPs, at least about 3 weeks they should be off contact lenses before we go for refractive surgery. Then we usually do the normal checkup of intraocular pressure, then autorefraction and uncorrected and best corrected visual acuity, and we also do the manifest and cycloplegic refraction, and a thorough detailed slit lamp evaluation has to be done. So here rule out if there are presence of any scars, opacities, or if there is presence of any endothelial guttae, any other findings in this slit lamp examination should be noted. Then we do a dilated fundus examination, then corneal topography, preferably Pentacam as it's more accurate, and then we have the wave scan aberrometry. We also have to look at the pupil size both in the scotopic and mesopic conditions, and we do a dry eye evaluation. The simple dry evaluation would be enough in cases of Schirmer's 1, 2 and T-BUT, and if available and in special cases we would do specular microscopy and ASOCT. So coming to the basic steps of PRK, we have the first one, which is the epithelial removal, following which we gave the excimer laser ablation, and then we use mitomycin C, and finally the application of bandage contact lens. Now the epithelial removal can be done in various ways, but practically what we follow would be mechanical, chemical and the laser techniques. Now in cases of chemical techniques, we usually use alcohol, that will be ethyl alcohol, and we use 20% ethyl alcohol, And normally what we do here is, this is what we see here is the alcohol well. We keep it on the cornea and then we put a few drops of it inside the alcohol well, and we wait for about 20 to 30 seconds, and following which it is thoroughly washed. So always make sure that it's completely washed so that it does not cause any toxicity to the surrounding conjunctiva or the limbal cells. So once it's washed out completely, then we go for the epithelial removal, which can either be done using a Merocil sponge, or we can even use a hockey stick. Now this is a case of mechanical debridement, so where we see that we use a rod and we are removing the epithelium. So always make sure that do not go too much to the periphery, because it causes delayed epithelial healing. So it should be just about maximum of 8.5 to 9 millimeter. And also make sure that you do not make the bed very dry or very wet, because during the time of ablation it can cause later on undercorrections and overcorrections. So completely remove the epithelium. You can even use a Merocil sponge and make sure that the center part is clean. There should be no island of epithelium left between. So there is also another method of epithelial removal, which is called as trans PRK. So here we use the laser itself. This is called as the Johnson no touch technique. So here what we do is basically, as you can see here, in transepithelial PRK, we do not use alcohol or we do not go for a mechanical debridement. Instead, the laser itself will ablate the epithelium first, followed by the stromal ablation. So we have to remember one thing here, that epithelium is slightly thinner in the center compared to the periphery. In the center it is about 55 microns, and in the periphery it goes up to 65 microns. So it does a differential ablation based upon the thickness of the epithelium, and following which it does the stromal ablation at the same time. Now in cases of different machines, there are different ways it's been shown. This is actually a picture of what we use, that is the Alcon EX500, where it has got an option called as Streamlight. This is what we have to go for in cases of transepithelial PRK. Now this is in case of Schwinn-Damaris, where we use a scanning slit technology. Here again it does both epithelial removal and the stromal ablation together, that is the transepithelial PRK. So one thing we need to understand, so after this, after the epithelial removal, we go for the excimer laser ablation, and once the ablation is done, we will go for application of mitomycin C. Now mitomycin C, some people prefer, some people don't, but preferably it is good if we use it so that the chances of haze would be lesser. So we use 0.02% mitomycin C, and we keep it for about like 10 to 15 seconds, of maximum up to 20 seconds. And after that, give a very thorough wash and then put a bandage contact lens. So now coming to a little bit detail of the type of ablation and all that. So first we have what is called as a Wavefront optimized and the Wavefront guided ablations. Now to understand this simple concept, we need to first know what is a cosine effect. Now if we can see over here, the cornea is aspheric, and let's say that the laser beam is falling here and also in this area. So if we see that the same laser beam which is falling here and also is falling in this particular area, here the surface area becomes a little more compared to the central part. So what happens is the amount of energy which will be delivered to the periphery will be lesser compared to what is being delivered in the center. So when there is more amount of ablation happening in the center compared to the periphery, it leads to a little irregular pattern of ablation and will give rise to what is called as spherical aberrations. So to prevent this from happening, we do what is called as an optimized ablation profile. So in this, it is adjusted in such a manner that the laser energy that is delivered to the periphery is a little more compared to that of the center in a controlled manner. So it gives an optimized ablation, and thereby we do not induce the spherical aberrations. So this is what is called as a Wavefront optimized ablation pattern, which we normally use. Now there is also something called as a Wavefront guided. Now what is the difference between the two is that in case of Wavefront guided, what we do is already there will be some pre-existing higher order aberrations which we take into consideration, and we treat them also along with taking care of intraoperative induction of abrasion control. So the main difference is in Wavefront Optimize, we don't take into consideration the previous abrasions. We just make sure that intraoperatively we do not induce anything. But in case of Wavefront Guided, whatever the abrasions previously the patient has will also be treated. So in case of a normal eye, what would you go for? Either a Wavefront Optimized or Wavefront Guided. See, Wavefront Optimized would be sufficient enough, provided that the patient is not having very high preoperative abrasions. Now we also have something called as a topo guided abrasion, that is PRK. So which is basically what is a new thing which has come called Contura. Dr. Aparna will be talking about it later. So now just coming to the post-operative complications, a few of them which can be commonly encountered. The first important one is the pain. So usually the pain is predominant on the first evening of PRK treatment and gradually will improve over the next 24 hours. And usually we give them oral analgesics and topical NSAIDs, preferably the preservative-free ones, and they do pretty well. So we also have second one is the epithelial problems. So the epithelial problems are, it can be in the form of delayed epithelial healing. This can happen because of alcohol toxicity or if the patient has a preoperative dryness and in cases of diabetes. And they can also have persistent epithelial defect, which can happen again because of the preservatives in the medicine and because of medicine toxicity. Or there can be some recurrent corneal erosions. So in all these cases, always preferably use preservative-free lubricant drops and even lubricating gel. Next thing is dryness. So dryness, again, it can happen because of the ablation of the corneal nerves and also because of the pre-existing dryness. So in this, again, we normally use the preservative-free lubricant drops excessively. We can also add them on cyclosporin 0.1% BD, and if it is very severe, we go in for punctal plugs. But also make sure that if there's any meibomian gland, if there is any MGD, then always that has to be treated in the form of tablet doxycycline or again along with the warm compress and lubricants. Next thing is a corneal infiltrates. So it can either be in the form of a sterile infiltrate or an infective one. So whenever there is an infiltrate, always think as an infective one unless proven otherwise. So if this is a case like this, now first ask for the symptoms if the patient is having too much pain, redness, watering, photophobia. So usually in cases of sterile infiltrates, there is not much of symptoms, and usually the signs are also less in terms of congestion is much lesser and not much of an anterior chamber reaction, etc. So this is a case, but still we always go ahead with scraping and we make sure that it is not an infective one. And then the sterile infiltrates will do good with the topical steroids with antibiotic cover and of course the lubricants. So this will be a case of infectious keratitis. So here if we look at it, there is a lot of congestion, the circumciliary congestion, then there is anterior chamber reaction, and there is a dense infiltrate in the center. Also there is hypopion, and patient will also be very symptomatic. In these conditions, always do the scraping, look for the organism, and then start them on the fortified antibiotics. Next thing, we have something called undercorrection and overcorrection which can happen. So intraoperatively, if the bed is like too wet, and it can cause undercorrections, and also it can be because of the postoperative haze or even scarring, or if there is an aberrant or abnormal wound healing. So then there can also be overcorrection. So overcorrection can be because we have attempted a higher correction, or if the bed was very dry, that is excessive stromal dehydration prior to ablation can cause overcorrections, or if there is a low humidity in the room, and if excessive use of topical steroids or excessive mitomycin C when used can cause overcorrections. Next thing is a decentered ablation. So here we see that the center cross should usually be at the center of the pupil. Now in case, let's say the patient is excessively moving, or even before we start the surgery, it has been slightly off the center and the ablation is continued, then it can lead to a decentered ablation. So usually when we do a Pentagram, this is how the decentered ablation would look, wherein we see that it's slightly decentered here. So this can usually give rise to some irregular astigmatism, and the visual acuity might be affected. So the next thing is again irregular astigmatism, which can happen because of decentered ablation, or sometimes if postoperatively they develop ectasia, and if there is any differential wound healing because of annular haze. Then this is a case of corneal haze. So if we look at this, the second picture here, so this was the person who presented to us. He had undergone transepithelial PRK for hyperopic treatment elsewhere, and he came to us after 3 months. He had irregular astigmatism, and he had developed an annular haze. So in that case, we just put him on low dose steroids and also cyclosporin for 2 months and lubricants. Though the haze did not completely disappear, he did improve in terms of the astigmatism and the visual acuity. So the increased chances of haze happens when we go for a deeper ablation, like more than 80 millimeter. So that's why we usually keep it up to 6 diopters. So the deeper we go, the chances of haze will be more. And in cases of myopic corrections, as I said, more than 6 diopters, and hyperopic more than 3.5, the chances of haze are more. And in cases of smaller ablation zone, or when there is excessive use of, exposure to ultraviolet radiation. So that's why we always tell our PRK patients to use UV protective glasses after the surgery. And if they have any ocular surface disorders, then also in cases of retreatments, when they've already undergone probably a PRK before or a Lassic before and we go for a retreatment, then the chances of haze are more. So in these cases, obviously we use mitomycin C to reduce the chances. So this is how our Wavelight EX500 chart looks like, which gives us the details about everything as to what is the refraction and what exactly is optical zone, etc. And here it also gives us how the pattern of ablation is. And intraoperatively, it also gives us the pictures and it tells us whether the treatment has been well centered or not. So just one of the picture of Pentagram, where if you look at it, they may not be very clear over here. The thickness is 479. It's slightly borderline. So in this case, again, the patient had a power of about minus 3 diopters. So in these cases, I would prefer to go for something like PRK to be on a safer side. So this is a Berlin Ambrosio display of the same patient. Now let us see, there's one more option lastly, what is called as a PRK extra, where we will be combining PRK with C3R. So what are the indications of this? Whenever there is a borderline topo or some topographic changes in the form of an asymmetric bow tie or a skewed radial axis and inferior steepening and a thin pachy, and in cases of significant posterior elevation, it's always better to combine it with a cross-linking to be on a safer side. So just an example, this is a picture of a pentagram. So where we can see that the thickness is about 490 micron, and also if you look at the bad display of this, there is both anterior and posterior elevation along with some deranged D values. So in these cases, it's always better. First look at the age of the patient, especially in cases of younger patient. If so, then always better you combine it with cross-linking so that the chances of future post PRK ectasia could be controlled. Now lastly, just I'll be showing a small video on Lassic. That is that was pretty much about PRK in short. Now this is a case of Lassic. Just a minute. So here again, what we do is we keep the alcohol well, and then we put ethyl alcohol 20%, wait for about 20 to 30 seconds, wash it thoroughly. After that, you can start scraping the epithelium. And in this, we do not completely remove the epithelium. We just keep a hinge of it. So just look at it. So in case of PRK, we would completely remove the whole epithelium and then go with the ablation. But in case of Lassic, a small hinge of it is left behind so that it can be reposited back. Okay, sorry. So then we follow with the laser ablation and then wash thoroughly, then reposit back this epithelium, which would act as a flap. Following which, just put a drop of antibiotic, put the bandage contact lens, and that's the end of the surgery. So